Today we will discuss the overview. First, the diabetes can lead to various complications if not managed properly. And complications can be acute or chronic, affects multiple organs. What are the complications? I have told you that this may be acute. What is acute complications? Hypoglycemia, when blood glucose level is less than 70 milligram per dl. Now, this blood sugar we measure from where? Sorry? Blood glucose from where? Capillary, tissue, or venous or artery? Venous, yes. Why venous? Any idea why we are measure venous? And what is the difference between venous and arterial blood glucose concentration? Which one is more? Which one is more? Artery or vein? Vein collects blood from intestine, from liver, from other muscles everywhere, and they carries glucose to the muscle, liver, all by arteries. So, venous we measure because whenever we are eating that has been absorbed and going to the vein first, which is carried to the artery and then it is distributed. So, we measure venous plasma. In capillary, what happens? The capillary blood glucose, though it is, we mean capillaries, but in that prick, the fluid is coming from the tissue also. So, there are capillary, lymphatics, tissue, all are there. So, there is a difference between the blood glucose in the capillaries, or what we are calling CBG, and venous. Theoretically, there is difference. One more important thing, this is a very important, though we know the definition of hypoglycemia is less than 70 milligram per dl, but sometimes it may happen that in a severely vasoconstricted situation, when blood is not circulating to the periphery, so if we measure the blood sugar level from this place and see that it is very less, though the patient is not having total body hypoglycemia, because due to someone has exposed his hand to a very cold situation and within the eyes, so circulation is less. So if you measure blood sugar at that time, it will be less. Even there are differences between right hand and left hand, between this finger and that finger. To get away with these aberrations, we, for measuring purpose, we measure one from venous plasma, which is there is no differentiation. What are the symptoms of hypoglycemia? Have you seen anyone have you seen any symptoms anywhere in your house, friend, the symptoms of hypoglycemia? Even have you felt yourself, say after fasting, or someone having severe illness, vomiting, he has not taken any food, the symptoms of what will be the primary presentation? there will be a shivering of the body, palpitation, sweating, dizziness, reeling, then loss of consciousness. And even this less than 70 milligram blood glucose level is prolonged beyond 30 minutes, then there may be a irreversible damage in the brain or kidney. So this is a very important acute complaint, and this is the most important complications of diabetes. So, treatment is 15-15 rule, 15 gram of glucose or carbohydrate, wait for 15 minutes, there is no change in the situations, recheck. Again give 15 grams of glucose. Next is diabetic ketoacidosis. This is DKA, is one of the most important complications, most severe complications also, because if we don't give due importance to this, if we don't keep it in our mind the possibilities of this DKA, we may lose the patient. In the conditions usually precipitated by infections or severe dehydrations, patient with high blood glucose level goes to diabetic ketoacidosis. Symptoms are hyperglycemia, metabolic acidosis. We detect ketones in the urine. Emergency management is required. That is a severe degree of dehydrations, usually stays shifting of the fluid from the vascular space to extravascular space. So that needs to be corrected immediately. So there needs to be given IV fluids and lowering of sugar by insulin, by a bolus and subcutaneous insulin infusion, or sometimes by intravascular insulin, by insulin pump. Insulin pump will release insulin. Say we fix up in the insulin pump that we have given insulin in this with normal saline, and we adjusted the dose. It will give a continuous insulin, say 1 units per hour or 2 units per hour, 4 units per hour, as we have said, and this will reduce the blood glucose level. So from very high, we will bring it down to a acceptable limit. Because if we reduce the blood sugar level beyond that acceptable limit, usually it is 240, then there will be shifting of the fluid from the brain cells, leading to intercerebral edema that further damages the brain. So this is a very critical management of diabetic ketoacidosis part. I will go in details in the management part. Another is hyperglycemic hyperosmolar state. Hyperglycemic hyperosmolar, when there is more than 600 blood glucose level, so blood becomes syrupy, thick, and when this thick blood passes to the narrow intratriate arteries, that gets clogged. That leads to dysfunction of the brain, loss of cognition, severe hyperglycemia, dehydrations, altered mental status. So we have to immediately give IV fluids and insulin to bring down the. So there is two different situations. Apparently both are hyperglycemia, but one is hyperosmolar and one is ketoacidosis. Differentiation is done by doing the urine test, and on inspection we will mail a sweet order from this breath order for acetone. Other is microvascular complications, retinopathy, damage to blood vessels in the retina, which leads to blindness ultimately. If we don't take a proper checkup, periodic checkup of the dilated eye. Nephropathy, kidney damage, risk chronic kidney disease, end-stage renal disease. Here also, the earliest change in diabetic nephropathy is, any idea? Rise of creatinine or rises of urea, shrinkage of kidney, or anyone? Any idea? Microalbumin, yes. Microalbumin is the earliest when there is the microalbumin level a certain more than 30 with albumin creatinine ratio goes up more than 30, that is the earliest change. So if we check periodically and find there is a microalbumin in the urine, so we should be very cautious and start medications in judicious way, fluid, electrolyte and diet management, so that the progressions from the early stage to further stage can be prevented. One thing is to be kept in mind, we cannot prevent the complication. We can only postpone the arrival of the complications. So, a patient at the age of 30 years, if he is diagnosed having diabetes, we know at the age of 40 years, his kidney will be affected. By 45 years, his heart will be affected, and by 50 years, his nerve and eye will be affected. So, if we maintain the blood glucose level and other parameters, metabolic parameters in a proper way, so that we can defer the complications by 10 to 15 years. So, what is very important at this aspect, that a country, a family, a society depends on earning for survival. So, if we maintain the health of our youth from 30 to 50, so that they need not go to hospital standing in the queue or in their bed for waiting for dialysis, it will be a great achievement, because if these people don't earn, their family will be suffering, society will be suffering, and ultimately nation will be suffering. So this is should be our aim, to catch them young and advise accordingly, so that we can postpone the complications. Next is neuropathy, nerve damage. It may be peripheral, autonomic and focal. Symptoms with numbness, tingling, gloves and stockings type of typical presentations of peripheral neuropathy. Pain, gastroparesis. Now, autonomic dysfunction, autonomic neuropathy, very common three conditions, you keep it in mind. Autonomic neuropathy means, any idea? What is the autonomic nervous system? Sympathetic and parasympathetic. Both have some sensory and some motor functions. Now, one important predeterminant of assessing or keeping in mind, that frightening is autonomic response, isn't it? Sweating, it is autonomic response. Palpitations, when you're running, our pulse is going up. So, this is also autonomic response. So, if these things are when the patient is having fever, high fever, but his pulse is not going up, so there must be something we should keep in the mind that there is a autonomic problem is there. So, what are the common conditions of autonomic neuropathy? It is a not related to diabetes, still I am telling you, keep it in mind. GAD or DAG, anything you mention, diabetes and Guillain-Barré. Another is one possible, I just forgetting, some poisoning is there, A stands for something else. So, diabetes is a important and Guillain-Barré, autonomic dysfunctions you have to keep it in mind. But these two cases you may face in the questions also. Third, I will keep you, when I remind it, I will mention it. What are the macrovascular complications? Coronary artery disease, heart attack, angina, cerebrovascular risk, stroke, TIA, peripheral artery disease, claudication, foot ulcer, amputations, risk factors are hypertension, dyslipidemia and smoking. Foot complications, foot ulcers, diabetic foot ulcers is a very dangerous ulcer. It is a require multi-speciality involvement, otherwise we may lose the foot of the patient by amputation. Often due to neuropathy and peripheral artery disease simultaneously happening. Infections, cellulitis, osteomyelitis. There is an increased risk of poor wound healing, we may go for amputations. And prevention is very important, daily foot checks, proper footwear, regular podiatry visits. How many of you keep checking your foot interdigital space? I often see younger generations going any places with just wearing a slipper. Have you checked your foot for any damage, cracks, anything? At your age group, if you are not having diabetes, you are very casual. But someone is having diabetes, this simple crack may lead to a dangerous complications. So, it is a very important to look into your foot also, not only face. Other complications, skin changes, acanthosis nigricans, necrobiosis lipoidica, gastrointestinal issues, gastroparesis, constipations and diarrhea, cognitive issues or cognitive decline, dementia. Gradually there is a similarly to the heart or brain, the vascular supply of the white matter is also reduced. So, there is a cognitive deficiencies and ultimately early dementia may be a features in diabetes. Infections, increased risk of bacterial and fungal infections. Diabetes is a multi-system and immunocompromised, but whenever there is infections, our bodies start fighting to it through a autoimmune response and neurological response. So, both autoimmune and neurological aspects are getting hampered in diabetes. So, it is a immunocompromised state when the patient is in uncontrolled blood sugar level. The infection will not, a simple cut injury will not heal due to secondary infections. Urinary tract infections will not heal if there is a sugar is not controlled. So, we have to not only AIDS, diabetes also may lead to severe immunocompromised state. Keep it in mind. Management, How to prevent complications? Tight glycemic control, blood pressure management, lipid management, lifestyle regulations, regular screenings of eye, kidney and foot, and lifestyle, diet, exercise and smoking cessation. We will come later on the diet part. Now, what is the key takeaways? So, diabetic complications are serious but often preventable. Multifactorial approach to management, patient educations and regular follow-ups are crucial. So, this is a basic overview of the diabetic complications. I will go some further regarding retinopathy. Diabetic retinopathy is, you keep it in ready for your short note also. This is two types. Basically, first it is non-proliferative diabetic retinopathy, NPDR, where there is a microaneurysms first, retinal hemorrhage, moderate is venous bleeding, intraretinal microvascular abnormalities, and there is severe. 4-to-1 rule. There is a hemorrhage, 4 quadrants, 2 quadrants of venous bleeding, 1 quadrant of intraretinal microvascular abnormalities. Basic pathology is microvascular damage and basement membrane thickening with pericyte loss. Proliferative diabetic retinopathy is the second. When there is a microvascular damage and pericyte loss, there will be new vessels growth, neovascularisis. Whenever there is damage, our body they release some vascular endothelial growth factor. These growth factors started angiogenesis. Angiogenesis means new blood vessels formation. Wherever you see, in heart also, everywhere, where there is a ischemic or any injury, body tends to do this, growth factors are there, they starts to do neovascularization. So, this neovascularization, new vessel growth, and this ultimately leads to fibrovascular proliferations. These fibrovascular proliferations, when there is fibrosis, they will pull up the retina, so there will be a vitreous hemorrhage, ultimately retinal detachment. And pathology is vascular endothelium growth factor mediated angiogenesis and endothelial cell proliferations. Third is diabetic macular edema. Macula, there will be accumulations of the fluid, hard exudate, cystoid macular edema, and pathology, breakdown of the blood-brain barrier, leakage of microaneurysms and capillaries. This part I want to mention because this will, if ultimately you have to prepare for MCQ. This is a very important class. What is the difference, basic difference? Microaneurysms are the features of NPDR. Neovascularization is the features of progressive diabetic retinopathy. Vascular permeability is macular edema, and fibrosis again ultimately progressive retinal detachment. These basic pathological differences are important. Here key molecular pairs is vascular endothelial growth factor, pigment endothelium derived factor and inflammatory cytokines, that is IL-6 and TNF alpha. So, how these complications in diabetes happens throughout the body? What is the basic mechanism? Microvascular complications is due to hyperglycemic induced damage. Chronic hyperglycemia leads to increased polyol pathway flask. Sorbital accumulations. Sorbital is an important pathway, giving to osmotic stress. Activations of the protein kinase C This causes altered gene expression. Increased advanced glycation end-products, AGEs. Oxidative stress and inflammation. Increased hexoamine pathway flash, they all altered protein function. So this is due to hyperglycemia itself causing damage to the end organs. Next is oxidative stress and inflammations. Hyperglycemia generates reactive oxygen species, ROS. Have you read in the physiology? You have completed pathology also. These ROS, reactive oxygen species, are dangerous. They produces some oxidative stress in the body and ultimately leads to inflammations and fibrosis. Endothelial dysfunctions, hyperglycemia and oxidative stress impair endocrine functions by reducing nitric oxide production, and that leads to vasoconstriction. So nitric oxide production reduction is an important factor. Increased endothelin 1, it also leads to vasoconstriction, increased vascular endothelial growth factor and angiogenesis. So microvascular damage, endothelial dysfunction, inflammations lead to thickening of basement membrane, loss of pericytes and endothelial cells, increased permeability and leakage, microthrombi formations. So this is a general overview of pathogenetic procedures of diabetic complications, and we get manifested in retinopathy, nephropathy and neuropathy, all same type of pattern is there. Diabetic nephropathy, again I am coming back, hyperglycemia, glomerular hyperfiltration, same procedure, increased glucose, increased sorbitol, osmotic diadosis, rash activation, efferent arterial constriction, increased glomerular pressure, hyperfiltration. Then there is glomerular hyperfiltration leads to mechanical stress, podocyte injury, loss of slit diaphragm, proteinuria, and here it starts that albuminuria. Hyperglycemia leads to increased AGEs, rage activation, inflammations and fibrosis. Again hyperglycemia leads to increased TGF beta, mesangial cell proliferation, extracellular depositions and glomerulosclerosis. And ultimately this proteinuria, there will be tubular cell injury, inflammation and fibrosis lead to tubular atrophy. So all this mechanism, what is the basic procedure which leads to these complications? This is anyhow there is a first vasoconstriction, damage of the cells and inflammation, fibrosis and loss of the cell. So this pattern is followed everywhere. So if we ask only one point which is the most important part of this complication management is to prevent vasoconstriction. Everywhere the problem starts, ultimately damage comes to vasoconstrictions in all aspects, all micro. So this part we have to take care when we are thinking how to manage the situations. Stages of nephropathy. First is hyperfiltration. There will be increase of glomerular filtration rate. We usually measure by EGFR, estimated glomerular filtration rate. It is a calculation. Now it is in vogue. Everyone is advising. So previously it was not easily available, this report. Next is microalbuminuria, 30 to 300 milligram per day. Stage 3 is macroalbuminuria, more than 300. And stage 4 is reduced GFR, CKD stage 3 and 4. and stage 5, end stage renal disease, that is CKD stage 5. So, you see at which level if we and this jumping of stage 1 to stage 2, stage 2 to stage 4, it takes years. So, if we effectively control this, so we can postpone the complications. So, therapeutic targets for reductions of the vasoconstriction, RAS blockade, AC inhibitors and angiotensin receptor blockers. Glycemic control, SGLT2 inhibitors, GLP-1 agonist. Proteinuria reductions, RAS blockade and SGLT2 inhibitors again. And inflammations and fibrosis, there are emerging therapies.